Hello, my name is Kelsey Hatchett, and I am a neonatal outreach coordinator and staff nurse in the Level 4 NICU at UMC Children's Hospital in Lubbock, Texas. Today, we're going to be talking about specialized care for VLBW and ELBW infants and discussing the processes and policies we use in our unit that you hopefully will find helpful for your own facility. In this presentation, we will be discussing different birth weight classifications, delivery room considerations, a population-specific checklist, golden hour stabilization, and specialized care recommendations. To begin our discussion, let's briefly cover the difference between low birth weight classifications. Infants born with a birth weight less than 1,500 grams are defined as VLBW, or very low birth weight, whereas infants born with a birth weight less than 1,000 grams are defined as ELBW, or extremely low birth weight. As a play on our hospital's hometown, we refer to our specialized care of these patients as LBK, or little baby care. The little baby care protocols and care recommendations are used on any baby born less than 32 weeks gestation or any baby with a birth weight less than 1,500 grams. I wanted to add a brief slide discussing our LBK team in training. During the standard orientation process, all of our RN staff members receive thorough education and training for all gestational ages and acuity levels. They're trained to care for grower, intermediate, and critical patients whose care may range from routine feeding to intensive care for intubated patients on a ventilator. After their weeks of training, they will take patient assignments on their own for many weeks and months. After 1 year from beginning orientation, the nurse will go back on orientation to receive training for attending deliveries. During this time, they will have a preceptor educate them on equipment setup, delivery room resuscitation, and specialized care for LBK deliveries. We provide each NICU nurse with LBK training prior to completing their orientation process. Once the nurse completes their delivery orientation, they will go back to taking their own patient assignments, which can include an assignment on the delivery team for the shift. Each shift has a designated delivery team, including the primary delivery nurse, the backup delivery nurse, a writer or a person solely responsible for delivery room documentation, and a respiratory therapist, as well as a neonatologist or neonatal nurse practitioner. Often, if the delivery is low risk, the backup delivery nurse will serve as the writer or documenter for the delivery. I've included a video link that's made by one of our NICU nurses that details how we set up for our LBK deliveries. Over the next few slides, we're going to cover the detailed steps for setting up the delivery room for small and preterm babies. First, let's discuss ways to optimize thermal regulation. On each LBK delivery, we increase the delivery room or OR temperature to 78 degrees. A pre-warmed isolette should be taken and set up in the delivery room prior to the patient's delivery. For emergency cases that leave us with little time to set up and prepare for the patient's delivery, we always keep a pre-warmed isolette by the connecting door to our family birth center, so it connects both the NICU and the family birth center, so we keep one just right there. The isolette should be set to air mode with a minimum air temperature of 36 degrees Celsius. The isolette should be equipped with a battery pack to keep the isolette powered on and heated during transport from the birth center to the NICU. Once the patient delivers, axillary temperature should be monitored frequently until normothermia is ensured. While the top of the isolette is open or raised, axillary temperature should be taken every 5 minutes. After the patient is stabilized and the isolette top is closed, axillary temperatures can be spaced out to every 15 minutes until the patient's normothermic. Immediately after the baby delivers, the patient will be gently patted dry by the OB team and placed in occlusive polyethylene wrap. We use the NeoHelp ponchos that allow us to tighten the plastic wrap around the head of the baby with a drawstring and place a hat over the plastic. A chemical thermal mattress should be readily available to activate if the infant's axillary temperature falls below 97.9 degrees Fahrenheit. If environmental circumstances are appropriate, you can consider removing the chemical mattress once the patient's temperature is sustained between 98.0 and 99.5 degrees Fahrenheit. Additional humidification will be implemented once the patient is transferred to the NICU and initial admission procedures are complete. We will discuss routine thermoregulation in the NICU in more depth in the coming slides. Based on the 9th edition NRP recommendations, umbilical cord clamping can be deferred in vigorous preterm infants for at least 60 seconds. For non-vigorous preterm newborns, umbilical cord clamping can be deferred while the OB dries and stimulates the infant to breathe during the initial steps of newborn care. In cases of placental abruption, bleeding placenta previa, or cord avulsion, where placental circulation is not intact, the umbilical cord should be clamped immediately. The latest changes from NRP include recommendations for cord milking. However, there is not enough evidence to recommend routinely milking the intact umbilical cord. For patients less than 28 weeks, umbilical cord milking is associated with a higher risk of severe IVH and should be avoided. Preterm infants are more susceptible to lung injuries, so it's important to use the lowest pressures possible to achieve adequate ventilation. If the infant is breathing spontaneously, it may be appropriate for the provider to consider CPAP as opposed to intubation. Starting ventilation pressures for preterm infants include a PEEP of 5 to 6 and a peak inspiratory pressure, or PIP, of 20 to 25, with the maximum inspiratory pressure being 30. Surfactant is taken on every LBK delivery. If the patient requires intubation for respiratory distress or is extremely preterm, surfactant administrations should be considered. Methods of administering surfactant include LISA, or least invasive surfactant administration. MIST refers to minimally invasive surfactant treatment. SALSA, or surfactant administration through a laryngeal or supraglottic airway. And ENSURE, which refers to intubate, surfactant, then extubate. Our hospital uses the ENSURE method for administering surfactant replacement. A T-piece resuscitator, like a Neopuff, should be used for ventilation to deliver precise and consistent pressures throughout your resuscitation. Quality resuscitation is crucial to the outcome of all babies, especially those born prematurely or with low birth weight. Evidence shows that achieving an SpO2 of 80 to 85% within the first 5 minutes following delivery is associated with improved survival and neurological outcomes. During the resuscitation period, LBK infants may require higher FiO2 concentrations or may need faster titration for more or less oxygen. While you're setting up the T-piece in the delivery room, you will adjust the oxygen blender to the appropriate percentage based on gestational age. For patients less than 32 weeks, NRP recommends starting with at least 30% FiO2. After delivery, you will monitor the infant's preductal saturations and increase the FiO2 in increments of 20 to 30% every 30 seconds until the target saturation is reached based on minutes of life since delivery. Part of our routine setup for all LBK deliveries includes having a ventilator prepared and ready to go. This allows us to transfer babies back to the NICU connected to the ventilator and continue using the RAM cannula for CPAP or NIPPV, or continue delivering consistent, precise pressures to intubated babies. Protection from neurologic injury begins even before delivery. Once the infant is in our care, it's incredibly important to continue prioritizing neurologic protection. While we are resuscitating in the delivery room, handle each infant gently and minimize the noise level in the room as much as possible. Limit contact with the infant that could be potentially painful or otherwise noxious. If the patient requires intubation, it's best to avoid repeat attempts. If you are able to successfully ventilate the infant with a T-piece and mask, offer breaks in between attempts to allow vital signs to stabilize in time for the infant to recover. Always keep the baby's legs lower than the level of the head to minimize the risk of IVH or intraventricular hemorrhage. Once stabilized in the NICU, elevate the head of the bed 30 degrees to assist with reducing cranial pressures. This is the checklist we use to remind delivery and admission nurses of population-specific priorities. This checklist applies to any patient born at less than 32 weeks or weighing less than 1,500 grams. Copies of this checklist are kept on our NRP cards that we take to each delivery, which allows a quick reference to remember unique priorities for LBK deliveries and admissions. Okay, so now we're going to transition to the golden hour and discuss things we've done to help us meet our goal of stabilizing even our tiniest patients within 1 hour. These standards derived from a unit-wide project we did to identify areas we could improve and optimize our golden hour stabilization. Our goal is for the patient to be stabilized in the delivery room and transported back to their room in the NICU in 20 minutes. This time begins at the time of birth and concludes once the patient arrives to the NICU. From there, the top of the isolette is raised for additional stabilization and care measures. Our golden hour begins from the time of admission and concludes once the isolette top is closed. These times are calculated and tracked based on nursing documentation in the chart. The admission nurse is required to place a comment in the chart specifying the exact time the isolette top was closed. During this time, it's important for the bedside nurse to document the specific time X-ray arrived at the bedside, anytime there's communication with the provider, or if the provider arrives at the bedside for any reason, and any thermoregulation interventions. During the golden hour, it can be difficult to filter through all of the to-dos and prioritize tasks in an appropriate order. To standardize this process, we've created a flow of admission priorities beginning with cardiorespiratory stabilization. Once the patient arrives to the room, Q15-minute vitals should be initiated and electronic blood pressure readings set to automatically cycle every 15 minutes. If the patient is intubated, the ET tube should be repositioned and secured, if necessary. ET tube repositioning is directed by the provider. An initial weight should be obtained for appropriate orders, umbilical line placement, as well as fluid and emergency drug sheet calculations. The transport nurse or provider designated to insert the UVC and UAC should prepare all supplies and be sterile and ready to insert the lines upon the patient's arrival to the NICU. This is the best way to avoid needing additional IV access. However, you will never be wrong for inserting a PIV to get access sooner if central line insertion is taking additional time. Any patient weighing less than 1,500 grams will receive a UVC unless otherwise directed by the physician. All IV fluid, medication, and lipid tubing should be connected and primed using sterile technique. The tubing should be kept sterile during the admission process so it can be connected sterilely by the person that inserted the UVC. If peripheral access is necessary, attempts should be limited to avoid delays in exposing the patient to additional pain. If there is an orientee assigned to the admission nurse, they will be allowed one attempt. If they are unsuccessful, the preceptor will attempt once. If the preceptor is unsuccessful, the charge nurse or transport nurse should be called to the bedside for remaining attempts until access is established. Once venous access has been established, fluid should be immediately started. Hypertonic solutions should be avoided in LBK patients. In most cases where UVC insertion was successful, heparinized starter TPN with calcium and dextrose concentration between 5 and 10% will be ordered by the physician, usually at a starting rate of 100 milliliters per kilo per day. If central access was not successful, the same fluids minus the calcium will be ordered. If UAC insertion was ordered and successful, sodium acetate with heparin should be infused between 0.5 and 1 ml per hour as ordered by the physician. During this time, the nurse should administer any ordered fluid boluses. Ordered labs and an initial blood sugar measurement should be obtained during venous access establishment. Once IV fluids are infusing, the nurse should prioritize stabilizing the patient's blood sugar and ensuring continuous normothermia. While the top of the isolette is raised, axillary temperatures should be obtained every 5 minutes and can be spaced to every 15 once the isolette is closed until the baby is normothermic. To simplify priorities during the admission process, we created a flow of phases. Priorities in phase 1 include obtaining vital signs at the appropriate frequency, getting an initial weight, and preparing the patient for central line insertion. During phase 2, the admission nurse should prioritize IV access and insert a peripheral line when appropriate. Once access has been established, the ordered maintenance fluids should be started immediately. In the third phase, priorities include administering any boluses that may be ordered, like normal saline or D10 for hypoglycemia. Although thermoregulation should be a constant priority, The admission nurse should focus on closing the top of the isolette if they haven't already done so and ensuring the patient is normothermic. The admission nurse should also continue reevaluating the infant's blood glucose at appropriate intervals to ensure the patient remains normoglycemic after post-delivery stress and initiation of dextrose-containing IV fluids. Subsequent dextrose boluses or changes in IV fluid dextrose concentrations may be ordered. Small and preterm infants are especially susceptible to rapid heat loss. It is crucial to remain diligent with thermoregulation to avoid hypo or hyperthermia. To reduce the incidence of hypothermia in the delivery room, we implemented a few different practices and continued to monitor data for improvement. After tracking and trending the data for a few months, we saw significant decreases in the hypothermia occurrences. For all LBK deliveries, the birth center room temperature is increased and maintained at 78 degrees. Following delivery, the infant will immediately be placed into occlusive plastic wrap with a thermal mattress readily available to activate if needed. A chemical thermal mattress is typically activated when the patient's axillary temperature falls below 97.9 degrees Fahrenheit. If the mattress is activated and placed under the infant, the mattress should be removed when the infant's temperature is between 98.0 and 99.5. Your thermoregulation interventions will be guided by your trend of axillary temperatures that should be taken every 5 minutes until the patient is stabilized in the NICU and the isolette top is closed. At that point, temperatures can be spaced out to every 15 minutes until the patient's normothermic. If the mattress is removed and the patient's temperature begins to decrease again, place the mattress back under the infant. The chemical mattress will remain warm for quite a while. Do not remove the infant from the plastic wrap until the isolette has warmed back up to an appropriate temperature. The patient's axillary temperature is above 98 degrees and the isolette has fully humidified to the set temperature. 70% humidity is initiated on all infants weighing 1,200 grams or less. If a baby weighs less than 500 grams, a higher humidity level may be necessary. The starting humidity percentage will remain the same for the first week of life. After that, humidity can begin weaning by 5 to 10% each shift until 40% humidity is reached. Humidity can be discontinued after 40%. Stabilizing the infant's blood sugar is the next priority during the golden hour. Each facility may have slightly different protocols. However, we almost always use a routine order to check the patient's blood sugar every hour for 3 hours. If each reading is above 50, blood sugar checks can be spaced to every 6 hours. It's important to report any glucose value that is not within normal range to your provider and document your communication, as well as any new orders or interventions you may receive. There are circumstances during admission that could potentially influence the necessity for intervention. During the golden hour, the infant has likely not had IV fluids infusing for very long. If your initial blood sugar is low, it is possible that the provider may be comfortable repeating the blood sugar in 15 to 30 minutes to see if the infusing fluids are successfully increasing the patient's blood sugar. However, you should never assume that the provider will be comfortable without intervention. You should always communicate any abnormal reading very quickly. If UVC insertion is taking a prolonged period of time, it may be necessary to obtain a peripheral IV to begin infusing fluids. It is appropriate to wait to check your first blood sugar until access is secured. However, you should obtain the first value by the end of the golden hour or sooner. The admission team has the best chance at stabilizing the patient's glucose within the golden hour time frame if there is prompt communication of glucose values with the provider and any ordered boluses are given immediately. The next priority during the LBK admission process should be administering medications. Most of the time, there are multiple medications ordered upon admission. It can be tricky to determine which medications should take precedence over others. We created this list of commonly ordered medications that should be the highest priority. Each admission will be different and your sequence of administration will change based on the patient's needs. Medications that should be prioritized for administration include surfactant, fluid boluses, continuous medication infusions or drips, maintenance fluids, and antibiotics. Now that we have discussed the priority pieces of LBK admissions, let's talk about the admission steps that can wait. Measurements including girth, FOC, length, and chest are held for the first 72 hours of life. Once 72 hours of life is reached, the nurse will record all of the necessary measurements. It is not necessary to wait 72 hours to get the patient's footprints. However, you do want to be very careful in doing so to avoid elevating the legs. Be mindful of maintaining leg position below head level to minimize the risk of potential IVH. We try very hard to get a set of really good footprints on note cards to give the patient's family so they can have something comforting to take with them. Lower priority medications can be administered after the patient has been stabilized and all other priority medications have been given. Some of the medications you may consider holding until this point include erythromycin, vitamin K, caffeine, and the hepatitis B vaccine. Here at UMC, we wait to administer the hepatitis B vaccine until the patient reaches a weight of 2 kilos or turns 2 months old, whichever comes first. I added the last bullet point just in case it applies to your facility. We used to assess for the presence of a red reflex with the ophthalmoscope on every single patient upon admission. It was part of our standard admission process. When we refined our admission procedures, we determined that there was no reason to continue including this in our assessment and this could be assessed by the physician later in their stay. This may or may not apply to you, but I included it as something to consider if it is relevant to your facility. Providing age-appropriate developmental care is critically important in NICU care. I wanted to discuss the key pieces that should be considered in the care of VLBW and ELBW infants. First, we want to cluster our care to group as many tasks together as possible to reduce the number of times we disturb the patient. This may include potentially working with your other team members caring for the patient to find appropriate scheduling for things like lab draws and blood gas sampling. If the infant has ordered labs due at 1500, but your next blood gas is due at 1400, be mindful of communicating this information to the provider to potentially reschedule either your labs or blood gas in order to draw all of them at once and avoid unnecessary line access, heel sticks, and patient disruption. You want to minimize the noise level in the patient's room, even if the patients are in isolates. Even noises that don't seem loud to us can exceed the acceptable decibel level for preterm infants. In our unit, we have purchased noise level indicators that look like traffic lights. If the light switches from green to yellow or red, noise levels should be reduced. Utilizing isolate covers to maintain a dark and quiet environment to mimic the natural environment in utero as much as we possibly can. Isolate covers should be used on any patient with a gestational age of 33 weeks or less. Boundaries and comfort measures should be applied to completely surround the infant. 360-degree boundaries should be maintained as much as possible. You can use things like snuggle-ups, t-shirts, blanket nests, cloth straps, or approved weighted comfort devices like Zackies or Frogs. Cycled lighting should be used throughout the unit. Here we have what's called siesta time, where the main lights in the hallways are dimmed from 2 p.m. to 4 p.m. to allow for optimized rest. Lights are dimmed again at 7 p.m. and remain dimmed until 7 a.m. When indicated, pain control and sedation medication should be administered. Close monitoring of pain signs is important and must be communicated to the provider if pain medication is not already ordered. Pain medication and sedation should be administered appropriately and prioritized ahead of time when potentially painful procedures occur. While our tiniest patients are in the unit, it's important to find ways for parents to feel connected and involved. Offering skin-to-skin and kangaroo care is a great way to facilitate bonding that benefits the baby and the parents. Kangaroo care should be offered to every single patient at least once a day unless they are not stable enough to tolerate additional handling. I will talk more about kangaroo in the coming slides. In addition to kangaroo care, parents and family should be incorporated into hands-on care times as much as possible. When it's appropriate, offer for them to help take the baby's temperature, change their diaper, perform oral care with breast milk, offer hand hugs, and comforting touch, repositioning during each touch time. In our unit, breast milk should be used for oral care on all non-PO feeding infants, regardless of the size or gestational age of the patient. Unfortified maternal or donor breast milk can be used. Once it's fortified, you can no longer use it for oral care, so you will have to separate out some unfortified milk to use when you're performing oral care. To facilitate symmetric growth and development, positioning aids should be used. Things like weighted Zackies and frogs, as well as blanket nests, snuggle ups, gel pillows, and others can provide comfort and encourage proper development. All infants in 32 weeks and less will receive an order to be evaluated by occupational therapy. During handling and positioning, you should rotate the infant's head side to side if they are prone longer than one touch time. When the infant is prone, flex their hips and knees toward their chest, turn their feet in and not frogged out, and use a prone roll extending from the patient's shoulders to the hips for support. While they're side lying, no neck roll should be used. A t-shirt roll can be placed between the legs for the infant to hold and prevent the knees from touching. Extremities should be flexed in a neutral position, and all extremities should be contained in the nest or snuggle up. I wanted to include this slide because I know it pertains specifically to your facility. And while four-handed cares is not something we have implemented into our policy, it is something that we routinely practice. Two-person care times, particularly for those intubated babies, enhances safety by providing extra assistance to turn the infant and the ventilator equipment without dislodging the ET tube. Four-handed cares also provide additional comfort to the infant with extra hands to offer calming touch during stimulating times. So here's another slide and our policy regarding kangaroo care. After one of our recent quality improvement projects, we've really kind of revamped this process. So here's some of the newest changes that we implemented. Within reason, kangaroo care can be facilitated regardless of intubation status, lines, tubes, drains. Evidence has proven that skin-to-skin contact decreases nosocomial infections, improves breastfeeding outcomes, has a stress-reducing effect on the baby, reduces their length of stay time, and can help normalize blood sugar and regulate body temperature. Infants that meet criteria should have no clinical deterioration of condition within 24 hours before kangaroo care. The patient's lines and tubes must be well secured. The parents and or a significant other should be willing to provide kangaroo care for at least 1 hour. So you want to make sure that they have gone to the bathroom and that they're ready to go, have everything right there so that they can stay committed to kangaroo care for a longer period of time and avoid getting the baby out and putting them back 15 minutes later. Finally, the infant's axillary temperature prior to kangaroo care should be at least 98.0 degrees Fahrenheit. Patients that would not qualify for kangaroo care include any infant with a chest tube, any infant on vasopressors, LBK infants who are still within the 72-hour period where they should remain midline and supine, patients who are on minimal stimulation, infants on the cooling blanket for whole body cooling, any infant that has had an acute or sudden deterioration in condition within the past 24 hours, and any infant with a peripheral arterial line. If there are any additional questions or concerns regarding the patient's qualification for kangaroo care, you should always communicate with your provider first and make a collaborative decision. Now we're going to talk about ROP, IVH, and chronic lung disease prevention. Retinopathy of prematurity is a disease causing abnormal development of the retinal blood vessels. ROP can lead to significant vision impairment, detachment of the retina, and even blindness. While there are many risk factors for developing ROP, I've included several of the top risks that are relevant to our discussion of VLBW and ELBW infants. In utero, retinal angiogenesis is not complete until about 36 to 40 weeks gestation. Thus, a huge risk factor for ROP is prematurity and low birth weight. Other risk factors include intraventricular hemorrhage, hyperoxia, and maternal risk factors like hypertension and diabetes. Maternal hypertension is associated with an increase in anti-angiogenic factors that act as antagonists for VEGF, vascular endothelial growth factor, In other words, hypertension increases the production of factors that counteract the protein responsible for forming new blood vessels in the eye. Other considerations for ROP include antenatal corticosteroid administration, which has been associated with a decreased risk of ROP, an exclusive human milk diet, as well as omega-3 fatty acids and certain multivitamins. Certain vitamins, particularly vitamin A. Evidence shows ROP benefits with vitamin A administration and the use of fish oil lipid emulsions, as opposed to soybean lipid emulsions, are more beneficial. The screening criteria for our NICU specifies that all infants with a birth weight less than 1,500 grams and all infants born at 30 weeks gestation and less will be screened and examined by an ophthalmologist for ROP. The first exam will occur within the 4th week of life. In the delivery room, monitor pulse oximetry and adjust the blended oxygen to meet suggested NRP target saturations. Once stabilized in the NICU, guidelines for adjusting oxygen therapy are initiated. For any infant on supplemental oxygen, regardless of gestational age, the goal saturation range is 90 to 95%. Alarm limits should be adjusted appropriately and set to a range of 88 to 96%. This will alert the care team to a need for additional oxygen or indicate a need for weaning oxygen. Oxygen percentage should be adjusted to provide the necessary percentage to maintain saturations within the recommended range. However, oxygen should be weaned as much as tolerated by the patient to ultimately reach 21% or room air. Proactive oxygen adjustment can prevent negative effects of hypoxia and hyperoxia. Now looking to our IVH prevention. To minimize the occurrence of IVH, avoid hyperextending the neck, particularly during the intubation process. Always handle the infant gently. Infants 29 weeks gestation and less should be kept midline and supine, and measurements avoided for the first 72 hours. You want to maintain a 30-degree elevation in the head of the bed to keep the legs below the level of the head. Blood pressure should be closely monitored and pain well managed. If fluid boluses are ordered, do not administer them rapidly and avoid infusions of hypertonic solutions. When possible, utilize the Hummy device for blood sampling and avoid rapid aspiration of blood. Recently, our NICU did a deep dive into the ways that we could optimize our chronic lung disease prevention and revised our practices to give our babies the safest care. In the delivery room, all intubation equipment should be prepared and quickly accessible for the provider to insert an advanced airway in as little time as possible. After the baby delivers, apply a pulse ox and monitor saturations closely. Continually assess the patient's respiratory status and provide an appropriate level of support to minimize work of breathing. Assist with intubation when indicated by the provider. Promptly communicate concerns or changes in assessment to the physician. Always use a T-piece resuscitator for ventilation when possible. When appropriate, consider a trial of CPAP or NIPPV as opposed to intubation. Surfactant should be taken on all LBK deliveries by the NICU delivery nurse and kept readily available for the delivery room administration when indicated by the provider. Additionally, a ventilator should be taken on all LBK deliveries, and patients requiring CPAP and mechanical ventilation should be switched from the T-piece to the ventilator prior to leaving the delivery room. The patient will be transported back to the NICU in their isolette and connected to the ventilator. Once the patient is admitted to the NICU, FiO2 should be weaned as tolerated to 21%. Nasal skin protection devices should always be used. If the infant is intubated, you want to avoid routine suctioning and only suction the ET tube when it's indicated. If ET tube suctioning is necessary, always use a sterilely connected inline suction catheter. So that concludes our discussion over very low birth weight and extremely low birth weight infants. I hope that this was informative and helpful to you in your practice. I am happy to include any other topics that you may be interested in, or adding things to this particular presentation if that's something that you're wanting. Hopefully you can apply some of these concepts in your daily care of tiny babies, but I appreciate all of the work that you do, and I really thank you for hanging in there and learning a little bit about these smaller babies with me. Thank you so much.